So our codes here, right here, we know that we have somatic dysfunction. And we know that it's in the thoracic region. So we have a code of M99.02. We also have a somatic dysfunction in our lumbar area, M99.03. What I want to point out here with these two is that those are definitive diagnoses. So we do not assign code for symptoms when we have definitive diagnoses. So if you assign low back pain, thoracic spine pain, or muscle spasms, that would not be correct because we have definitive diagnoses. Our major depression, the patient was also here. That was one of the listed diagnoses at the very beginning. Back pain and depression. So for your principal or your first listed diagnoses, any of these three could be first. It would not matter. Obviously, you want to put your O2 and O3 on your M99 category to match your procedure, which is your 98925. But for the sake of entering into your first listed, all three of these brought the patient here. But the definitive treatment was on the back. The physician mentioned therapeutic drug monitoring. So the Z51.81. All right, next we want to look at the CPT coding here. The OMT, that's your osteopathic manipulative therapy. That was done on 1 to 2 body regions. Okay, so it was treatment for the somatic dysfunction, which is in both the lumbar and thoracic. So you're only going to link that 98925 to these two codes. It's not going to be linked to depression or your drug monitoring for your depression. All right, so we had an evaluation. We've got to assign our evaluation code. Our depression is considered chronic with progression. That gives us a moderate. Didn't have any data, so we're at a straight level, straightforward level. But we did have prescription ordered in our risk, which is probably one of the most common that I have found so far to give us a moderate in risk. So we have 2 moderates and 1 straightforward. We know 2 out of 3, 99214.
So when do we code depression to be recurrent? As
when they say it.
Okay, when they say
it. Yes.
Okay.
If he doesn't die, but you got that right. You did the F32.9.
Yes, I got it right.
I want everyone to think about this. Okay, what I want you to see here is all these different adjectives for the type of depression. So that tells me these are specific diagnoses that the physician can use. And yes, he's had it. And yes, we may in our mind think it's recurrent, but if you look up the definition of recurrent, then you're going to see it has its own set aside diagnosis, definition, and you're not going to assign it unless the physician states recurrent. And that's really true in a lot of your ICD-10 CM. You want to be very careful because it's so easy to assume that's recurrent, because I get it. I get what you're saying. I get your thinking process. But I know that that's a specific term. And if it's a specific term and it's not in my chart by the documentation, I cannot assign it. So that's a good question. I'm glad you brought that up. It gave us a chance to look at our index and just see. I mean, even as a single episode, if he specified that, we could code that. Or if this patient came in and he says it's the first time that he's had, this bout of depression, you can't assign that because the physician doesn't say it. So we want to be very careful there. That gave us a really good way to walk through and see the different terms and to explain and understand why we can't consider that recurrent.
Sorry. Can you please explain this therapeutic drug monitoring? How is it being done? What is it about?
The drug therapeutic monitoring?
Yes, the monitoring process. How is it being done? What is it for?
Let me go back to that and let's look at that, because he could have elaborated on that. All right. This is all he says, isn't it? In the patient's here, he's doing drug monitoring. We don't really know enough to even code that separate, because what he says right below that is he ordered, renewed, and stopped. That's his referral. That's what he calls monitoring. He reviewed them, he ordered, and he stopped. Which I don't see any that he stopped, except the Zoloft 50 milligrams, 1 by mouth daily times 3 days. And then he's going to stop that. And then you're going to go to 2 by mouth every day that you would start immediately. Okay. So that's a physician way of saying, hey, this is what I'm doing. It's medication. It is prescription drug management.